Cysticercosis. Human cysticercosis is acquired by ingesting T-solium tapeworm ova from either contaminated fingers or food. The larvae are liberated from eggs in the stomach, penetrate the intestinal mucosa, and are carried to many parts of the body where they develop and form cysticerci. 0.5 to 1 centimeter cysts that contain the head of a young worm. They do not grow further or migrate. Common locations are the subcutaneous tissue, skeletal muscles, and brain. Now the clinical features. Superficial cysts can be palpated under the skin or mucosa as pea-like ovoid bodies, but cause few or no symptoms and will eventually die and become calcified. Heavy brain infections, especially in children, may cause features of encephalitis. More commonly, however, cerebral signs do not occur until the larvae die 5 to 20 years later. Epilepsy, including new onset focal seizures, personality changes, staggering gait, and signs of hydrocephalus are the most common features. This is the figure showing neurocysticercosis, T2 weighted axial image of the brain showing multiple lesions of neurocysticercosis. Large arrows show the largest lesions. Now the investigations. Calcified cysts in muscles can be recognized radiologically. In the brain, however, less calcification takes place and larvae are only occasionally visible on plain X-ray. CT or magnetic resonance imaging will usually show them. Epileptic fits starting in adult life suggest the possibility of cysticercosis if the patient has lived in or traveled to an endemic area. The subcutaneous tissue should be palpated and any nodule excised for histology. Radiological examination of the skeletal muscles may be helpful. Antibody detection is available for serodiagnosis. Now the management and prevention. Albendazole 15 mg per kg daily for a minimum of 8 days has now become the drug of choice for parenchymal neurocysticercosis. Praziquantel 50 mg per kg in 3 divided doses daily for 10 days is another option. Prednisolone 10 mg 3 times daily is also given for 14 days, starting 1 day before the albendazole or praziquantel. In addition, anti-epileptic drugs should be given until the reaction in the brain has subsided. Operative intervention is indicated for hydrocephalus. Studies from India and Peru suggest that most small solitary cerebral cysts will resolve without treatment.